The CirQPOD system provides intrathoracic pressure regulation, or IPR therapy, to hemodynamically compromised patients who are intubated and receiving mechanical ventilation. It non-invasively increases circulation, blood pressure, and perfusion with the touch of a button. Active IPR therapy works by creating a negative intrathoracic pressure in between positive pressure ventilations. Studies have shown that this increases venous return, and thus preload, cardiac output, and mean arterial pressure, while lowering intracranial pressure to improve blood flow and perfusion to the brain and vital organs. Let's look at how active IPR therapy works. The body continually regulates intrathoracic pressure in response to hemodynamic demands. During normal spontaneous breathing, the negative intrathoracic pressure created during inhalation helps return venous blood to the chest and slightly lowers ICP. Spontaneous exhalation, on the other hand, increases intrathoracic pressure, which forces air out, slightly inhibits preload, and slightly raises ICP. However, when a patient is mechanically ventilated, this process essentially reverses. Without a spontaneous inspiratory effort, the intubated patient loses the preload assistance that negative intrathoracic pressure can provide. Instead, patients experience only positive airway pressures, and if PEEP is used, a continuous positive intrathoracic pressure results. Positive pressure ventilation often has unwanted side effects, such as decreased preload, cardiac output, and systemic blood pressure, as well as increased ICP. Whenever mean arterial pressure decreases and ICP increases, cerebral perfusion pressure and blood flow are reduced. A common clinical correlate is the bleeding patient who suddenly decompensates soon after intubation and mechanical ventilation. While PEEP is commonly used and may be critical to maintaining adequate oxygenation in certain situations of lung injury, some patients with poor organ perfusion may benefit from the improved blood flow that the CirQPOD provides. The CirQPOD may provide benefit to intubated patients who are experiencing the hemodynamic instability associated with poor circulation or insufficient cardiac preload, which may be reflected by low blood pressure. Let's look at how active IPR therapy impacts hemodynamics in a porcine model of hypovolemia, where the animal is mechanically ventilated but has sustained a 40% loss of its calculated blood volume and is hypotensive. We'll look at key hemodynamic variables. Here, we see airway pressure in green, aortic blood pressure in blue, right atrial pressure in black, intracranial pressure in pink, cerebral perfusion pressure in orange, cerebral blood flow in purple, and cardiac output in red. With each ventilation, positive pressure is generated. Prior to the bleed, the animal's blood pressure is 96/54 millimeters of mercury, and cardiac output is 4.9 liters per minute, which is normal for this model. Beat-by-beat readings for the other variables are seen here. Following the hemorrhage, the blood pressure has dropped to 69/37, and cardiac output is dramatically reduced to 2.4 liters per minute, almost half of baseline. At this point, IPR therapy is turned on to create a negative intrathoracic pressure of 5 centimeters of water. Notice how the negative pressure created between each breath causes an immediate decrease in right atrial pressure. This results in increased venous preload, cardiac output, and aortic pressure. The reduced right atrial pressure also lowers central venous pressure, which lowers ICP. As shown here, the lowered ICP and increased mean arterial pressure result in improved cerebral perfusion pressure and blood flow. Clinicians are able to titrate IPR therapy to a desired hemodynamic effect. When the IPR therapy level is adjusted to negative 10 centimeters of water, notice the further improvements in hemodynamics. In this example, the blood pressure improves to 88/46, and cardiac output improves by 31% to 3.5 liters per minute. In addition, oxygen saturation during IPR therapy is not adversely impacted, and once the CirQPOD is turned off, airway pressures return to pre-therapy levels. The CirQPOD is intended for use in patients who would benefit from increased cardiac preload, blood flow, and organ perfusion. It is contraindicated in patients with pneumothorax, hemothorax, hypertension, and uncontrolled hemorrhage. The safety and effectiveness of CirQPOD use in patients with compromised lung function have not been evaluated as of yet. Patients requiring PEEP to maintain adequate oxygenation, or patients with inadequate sedation or inadequate neuromuscular blockade may not tolerate the CirQPOD. In addition, close monitoring of blood oxygen saturation and perfusion are important when using the CirQPOD. The CirQPOD works within the ventilation circuit and controls the level of IPR therapy delivered to the patient. A reusable motor is connected to a single-use disposable blower, and that assembly is connected between the ET tube and the ventilator. The device combination delivers active IPR therapy and also continuously monitors airway pressure. The monitor displays the activity of both the ventilator and the CirQPOD. Purple text displays what the ventilator is delivering to the patient and what is displayed on the ventilator. Green text displays what the actual patient airway pressure is when the CirQPOD is in use. Prior to starting IPR therapy, turn the PEEP to 0 and confirm that the patient tolerates this. Continuously monitor the patient and adjust the therapy as needed to maintain the hemodynamic status and ensure that oxygen saturation is not impacted in a clinically significant way. The CirQPOD can deliver IPR therapy at pressure levels between -2 to -12 centimeters of water. In this example, we'll begin with -5. Once the CirQPOD is placed into the active mode, it begins ramping. The green line progressively lowers and continues separating from the purple line until the desired negative intrathoracic expiratory pressure level is reached. In this example, the ventilator is set to deliver a peak positive inspiratory pressure of 15 centimeters of water, but IPR therapy continuously lowers the airway pressure baseline by 5, so the patient is actually receiving a peak inspiratory pressure of 10, and the delivered tidal volume does not change. At this point, the patient's oxygenation and circulation status are reassessed. To change the IPR therapy setting, simply select the desired level using the up or down arrow keys and press Confirm. The CirQPOD will adjust to that level. Here, IPR therapy is being delivered at -10 centimeters of water, and the effect on airway pressure is shown here. If you wish to discontinue IPR therapy for any reason, you can wean by incrementally decreasing the IPR level, or simply place the CirQPOD into standby mode to immediately stop the therapy. IPR therapy has been evaluated in more than 30 preclinical and clinical studies. Recent research has shown that delivering IPR therapy in states of poor perfusion can reduce the level of vasopressor support needed, safely increase cardiac output, increase mean arterial pressure, and increase cerebral perfusion pressure. These studies and others have also shown that any decrease in oxygenation is not clinically significant. In summary, the CirQPOD system is a safe, supportive tool that acts synergistically with fluids and vasopressors for hemodynamic stabilization of intubated patients with compromised circulation. With the touch of a button, it non-invasively increases blood flow and blood pressure, thereby improving perfusion to vital organs. ZOLL Medical. For more information, please email us at info@zoll.com.